started. So, good afternoon, everybody, and welcome to the ADPC Treatment Committee meeting for May 13th, 2026. For those I haven't met yet, my name is Katie Jokinen. I'm an ADPC Commissioner and co-chair of the Treatment Committee alongside Bradley Buchheit. Before we get started, I'll ask Ashley to conduct roll call and confirm quorum.
Hi, everybody. Happy Wednesday. I'm going to run through roll really quick. Katie, I know you're here.
Here.
So Bradley,
Present.
great. Moxie, Heather, Christy, Judge Clara Rigmaiden,
Here.
Joe,
Present.
thank you. Mike, Mike here. Amy, no Amy. All right, Art,
Here.
thank you. Allison, Katrin,
Here.
thank you. Lisa,
Here.
and Beth,
Yes, here.
thank you. And I think we just hit quorum at 8.
Great.
We might have a couple of late joiners.
Awesome.
Thank you.
Thank you, Ashley. And then before we move into today's agenda, just a reminder that if anybody would like to make public comment today, please send Ashley a direct message or note it in the chat, and we'll reserve time for public comment at the end of the meeting. And so for today's agenda, we'll begin with director updates from Director Dahl. Following that, Mitch is going to help ground us in where we are with the EPIS framework and how that connects to today's discussion around the provider and treatment landscape assessment work outlined in the comprehensive plan. And then from there, the majority of today's meeting will focus on discussion, specifically helping us think through what questions can best be or only be answered directly by providers as we think about implementation of the comprehensive plan and understanding the realities within the treatment system. So with that, I'll turn it over to Director Dahl for updates.
Thanks, Katie. Annalise Dahl, Director at the ADPC. The full commission met on Monday this week. It seems like it was last week, but it was this week, and started an exercise talking about measures. I think, as everyone knows, we always talk about our big 3 outcomes that we're trying to get to: reduce prevalence, deaths, and disparities related to substance use disorder. But obviously, we need some measures in between here and there. And in our statute, we need to give guidance related to individual funding streams and programs, and we can't go through every program and do that. So starting to develop some of those high-level measures, which we will continue discussing next month. We will have a hybrid meeting where some of us are meeting in person in Portland with our friends at the Miracles Club, which is very exciting. The other committees, of course, are also busy. Recovery meets next week. They'll be hopefully, I think, wrapping up mostly their discussion about recovery community centers. You might remember they've been working on a definition. We don't have a definition for recovery community centers. So they had a summit, a little pre-session to Pearmageddon the week before last, and we'll be wrapping that work up. And then OYA actually meets later on today, the Oregon Youth Addiction Alliance, and they'll be hearing about family care plans, but then also focusing their conversation on youth-specific best practices related to recovery community centers. And they'll be feeding that information into the recovery committee. So that's a nice crossover there. The Health and Safety Interventions Committee then will meet the following week, and they are continuing on their deep dive on naloxone. probably this next meeting. Mara, correct me if we know for sure this isn't right, but we think we're going to be focusing on expired naloxone or soon to be expired naloxone. There's some perceived barriers to kind of getting that out to the right folks to make sure that gets used. So they're going to be diving into that. And then the prevention committee will meet to continue their conversations about a primary prevention the words just escaped my head, center of excellence, or hub or something along those lines, that they are scoping out. So those are my very high level. The opioid settlement board continues to talk about, it has one more round of funding to get out this biennium, one time $13 million. So hang on for more information. As soon as we know what that RFGA process will look like, we'll let everybody know. More exciting, I think, to us at the ADPC is once we get this funding out, we should have an idea of what the total opioid settlement funding is going to look like for the next decade. There have been about 3 kind of big outstanding settlements that some folks might have seen some press around recently. DOJ is very excited to be wrapping those up, and that will give us some more certainty about how much funding we have for the remainder of the settlement. And we'll be thinking about how we want to spend that money over the next decade. Those are all my updates. Always happy to answer any questions.
Thank you, Director Dolph. I am excited to hear about the expired naloxone because I think that is one of the most common questions I receive on what to do with it and if we can still use it and what to do with it if you can't. So I'm looking forward to hearing what comes of that conversation. So, all right. So, Mitch, up next, going to help ground us in where we are with the EPIS framework to help focus today's discussion. Take it away, Mitch.
Thanks. So first thing I have to tell you all, just because I don't often get to be excited about this sort of thing, this is my first meeting, I think, in almost 2 years where I haven't had to prepare a slide deck for you all because we get to just pull from your brains. And so I was just really happy to not have to do that. Not that I don't like doing it, but we actually just get to do stuff in your head today, which is cool. Um, so last month, I do have one slide I'm going to show as I kind of talk about this, but I didn't have to prepare anything. This is all from your last month's materials. But last time that you all met, we talked about a couple of our priority setting areas, like immediate workflows, and more than anything, really trying to figure out how do we almost like develop like a process model or a matrix model to explain why and what we're doing as we do it. And the best thing that I've found is the EPIS framework. And so the EPIS framework, just as a little bit of a refresher, because it's going to really, to what Katie said, is like ground us in where we're looking today. Is comprised of 4 words. EPIS is the letters, but exploration, preparation, implementation, and sustainment. I'm going to pull this on the screen really quick, just to show you what I'm talking about, in case it's been a month, you know. Really, the thinking here is that there are kind of 4 major things that affect implementation of evidence-based practices, and this is both at a program level and a systems level. So this is one of the reasons that this tool is so nice, or this framework is so nice. Today, my hope is that we live. Do I have a little laser pointer? Oh my gosh, I do. My hope today is that we live here. I would love for us to really be thinking about the inner context, is what EPIS says, but really the things that you are curious about that only the providers are going to be able to answer for us. So this is like the state, obviously, there's a lot of data we have. There's information we can look nationally. There's information we can look to community partners for. But in the comprehensive plan, there were a couple of near-term objectives about figuring out things like wait lists or figuring out things about practice fidelity or supervision practices or training. That all lives here. Now, obviously, there are going to be some things in the outer context that we'll talk about that are going to affect that, like how the funding gets there or things of that nature. But realistically, we are this bridging factor between those. So it's really important that we have accurate and timely information. So as we start to talk through what you want to be asking providers and how much of that information you're going to be asking them, because ideally we only have to do this at least once immediately, and then we can do it again later to check, and then maybe again later to see how it all went. But if we can figure out all of the unique things across all of these providers that we might be asking for this information from, maybe we can get a really good snapshot of the system that of where we are, but also where you all want to take it. So that's really kind of the grounding piece. And just because I know sometimes slides are a little weird, I did zoom in a little bit. So the things that I always like to kind of point out that exist in this inner context are things that are related to program leadership, the characteristics of those organizations themselves, how they monitor quality or fidelity throughout their organization, their staffing processes. So know that that processes doesn't imply only how many people they have. It could be how they hire, how they retain. There's a lot of stuff that could live in there. I'll put a little list in the chat when y'all start chatting. And then last, the individual characteristics. So like it could be that there are withdrawal management programs that you want to know about their prescribing habits, or it could be that you want to know about their referral pathway from withdrawal management to residential, or what happens when people say, I don't want any more care, or like what does that look like? So this is the opportunity for you today to be as creative as you want to say, if I had to unlock everything and say, tell us everything about your programs, what could we learn? Obviously, this will be distilled down over the next couple weeks and months before it goes out to the providers, and when we figure out how to do that, because we don't want it to be here's a limitless sheet of questions that nobody will answer as well. So we're going to kind of balance feasibility with the information you all want. But today, my hope is that we focus on inner context. But if we move really, really quickly, then we can talk about all this outer context stuff, which is ultimately going to be also really important, which is like, what is the leadership they want from maybe you all as the treatment committee? What are the policies that affect these practices, the funding supports, how they work between us and the state, the characteristics of the patients that they get or the clients that they get, and so on and so forth. But biggest thing, let's focus on like what the organizations and the providers need, because that'll kind of help us reverse back, which is also cool because that helps us almost stay in line with what the commission did this week. So they're focusing on the outcomes part, and we got to really focus on what the programs need. And that's all I have for you slide wise today. That's back to you, Katie.
Thank you, Mitch. I really think that framing is helpful because it reminds us that implementation doesn't just happen at the policy level, it happens inside organizations, programs, workflows, staffing structures, and day-to-day operations. So in the comprehensive plan, our committee identified several near-term objectives related to understanding the treatment system and provider landscape across Oregon. As Mitch mentioned, the focus today is really to answer what questions can best be or only be answered by providers themselves. Some things we can learn from claims data, contracts, statewide reporting, but many of the operational realities that affect implementation, like staffing pressures, workflow challenges, barriers to transitions, readiness concerns, sustainability issues, are things providers themselves are uniquely positioned to help us understand. And we're not necessarily trying to finalize a survey or assessment tool today. The goal is really to explore what information would be most meaningful to help implementation of the comprehensive plan, whether that's identifying barriers, understanding readiness, forming technical assistance, refining priorities, or helping us think about sequencing and sustainability. So we're also really fortunate to have Tim Rourke with us today from Third Horizon. Many of you may remember Tim from the comprehensive planning process. Tim has uh, Tim and his team have supported similar provider and system assessment efforts in other states and communities, and we thought it would be helpful to hear a few examples and lessons learned before opening discussion more broadly. So, Tim, would you be willing to help us get started by sharing a few experiences or words of wisdom from similar processes?
Sure, Katie, thank you. And hi, everyone. It's a pleasure to see some new faces and meet folks for the first time, and also a pleasure to see some folks that we worked with quite intensively over the comprehensive plan process last year. So happy to be back and pay you all a visit. Katie actually did a phenomenal outline and outlay of, I think, some of the key things that we would advise you to think about. I'll share a couple, and I'll share a couple of examples of some ways in which we've seen systems look to surveys to get at some of the very important work that you all talked about, and that Mitch and Katie just outlined. Um, and I think sort of reinforcing a couple of maybe guideposts for your conversation and thinking today. So there are a number of so our firm does this work all over the United States. We use surveys a lot. We're actually engaged with the prevention committee right now as a part of, you all may be aware, the prevention committee is focusing part of their priority work in the comprehensive plan was the implementation of House Bill 3321 that involves a programmatic evaluation and cataloging of primary prevention services in the state of Oregon. So we, as a part of that, are actually launching 3, maybe 4. Actually, I think it's 4 total different surveys right now as a part of that inquiry. And so for those of you who might touch prevention in your work, you might start to catch wind of some of those surveys as they go out. But to ground you in, I think, some conversations around what's possible and to spur your thinking around where you think you want to, where provider information can be most helpful in the implementation of the comprehensive plan. I'll throw a couple of links in. I might kind of do a quick visual on some things that we've certainly done or we've seen elsewhere. But the first one I'll start with is, and folks who remember who I got to know through the comprehensive plan process, I'm based in New Hampshire. We have a commission in New Hampshire, much like the ADPC, and I was its chair for about 8 years. So I have a pretty deep bench and body of work here in the state of New Hampshire. And we were tasked by that commission when I joined Third Horizon to conduct a financial analysis of the financial resiliency of the state's substance use system. So in this instance, the purpose of the provider survey was to look at their organizational financial health and the opportunities or challenges that providers were having in sustaining themselves. The what drove the need for the survey is that there was a disconnect between policymakers, the state agencies, and even some electeds saying there's a lot of money for substance use. So this was done in 2023. At the time, it felt like there was a lot of money flowing for substance use services. And yet, organizations on the ground were saying, we're on the verge of closure, we're economically unsustainable. So there was a very clear sense that there was a disconnect between the perception of the dollars available and the stability or fragility of the provider system. And key groups like the States Commission and others wanted to understand where the truth was and why that disconnect existed. And so providers were surveyed really explicitly to understand from their vantage point, what is their financial picture? How are they funded? Were they anticipating decreases or increases? How they are structured to think about financial resiliency. Do you have a line of credit? Do you use it? How are you running into challenges with administrative burden around, in the case of treatment providers, delays in claims reimbursement from Medicaid, delays in grant reporting or grant reimbursement, et cetera, et cetera. And so, and then that was overlaid with other information that we got from the state on, okay, where are the dollars? And what came out in that survey was that there were a bevy of administrative barriers around reimbursement, both in the insurance, particularly for treatment providers, in the insurance reimbursement space and in state contract reimbursement, that were actually slowing down the ability for treatment providers and other recovery providers to get access to the cash resources that they were contracted to receive. And that it was creating such a logjam that organizations were having to engage in some instances, not entirely appropriate shell games with their financing to keep their lights on. It also elevated that at a high level, dollars were being used for the wrong things. So in federal like dollars that we would collectively think of as perhaps more permanent, like block grant dollars or things of that nature, were funding work that was largely temporary or short term. And short-term dollars that were really volatile, not, were slated to end if it was like a time-bound federal grant, for instance, were paying for long-term infrastructure. So there was this real upside-down approach to fiscal policy, coupled with the administrative challenges providers were having. So in that instance, that was one where, if the survey, if we just looked at what the state felt, what the state was seeing, where the dollars were, that would have only been half the story. That we really needed to hear from providers and create a safe space where they could chime in with their information in a way that was anonymous, that we could capture some information, because we were asking providers to uh, share their vulnerability. And for some of them, going out publicly or being in a focus group and saying, yeah, I've got 30 days cash on hand, or I've got 2 weeks cash on hand, is probably not the most comfortable thing. So we really honed in that instance on not only questions that only providers could answer, but a survey was the right way to do it, because we were asking for information that was really, really sensitive. And we wanted to protect the anonymity of providers so that they could share the kind of sensitive information that the architects of the survey and those who asked to have it done needed in order to get the right information. So that's one example of a way in which these kinds of surveys can be particularly helpful. The other one I wanted to talk about is some survey work that our team did in Lee County, Florida. Lee County, Florida, for those of you who aren't familiar with it, large county in Florida, was decimated by Hurricane Ian some time ago. And when Hurricane Ian hit, there was, of course, significant investments from FEMA and disaster relief dollars that were afforded to the county. And they had they had a really unique opportunity and decided that they wanted to use some of those dollars to bolster the county's behavioral health ecosystem, because they recognized that as a region that was prone to natural disaster, they had some pretty unique factors that were driving their behavioral health challenges, both mental health and substance use. So they asked our group to do a very comprehensive survey of the provider system. So in this instance, whereas in New Hampshire, there was sort of a discrete group of questions, there was some specific information we wanted. We weren't asking providers to share all the things that we may want to know about providers. In the case of Lee County, and this survey was specific to treatment, the goal was actually a little more comprehensive. So I will show you this very quickly because it's just a nice overlay sketch of hopefully you can see that, what the survey entailed. So this survey had 6 different sections where we were asking about sort of general questions around the nature of the organization, how many people are served, what services are you providing, so that there was that sort of baseline capacity understanding. There was an ask about capacity to meet demand, and the extent to which people felt like they're not only are they providing the necessary services and people were able to access them, but patients that they felt needed other social services and supports in the region were getting them. There was a section around wait times, which I want to talk about in a minute, because I know that in the process of the comprehensive plan development, we as a group have talked about the issue of wait times and delays in care and challenges around transitions between different points in the care continuum, as well as some questions around access. We asked some financing questions. And then in the case of this region, they had a very specific priority plan, which was to develop a single entry point for easier referral access into the system for folks who needed care. So there was already sort of a proposal on the table to implement a specific strategy, and they wanted provider wisdom on how best to do that. So but I point this out because as you think about the universe of everything, this example is pretty comprehensive. The challenge to something this comprehensive is that can we actually get people to fill it out? And so, I would mind you as a group in this instance, we got a pretty successful response rate as it relates to the number of providers that were asked to complete the survey. That involved a lot of legwork on the part of the county, other community leaders to champion people to complete it, because it wasn't a survey that you could do in like 3 minutes. So it took some time because we were asking a lot of questions. What I'll tell you that came out of that, which was really interesting around wait times, is, and I know in speaking with Mitch and Annalise and thinking about this conversation, the treatment continuum is broad. You could choose, or you could decide that you want to explore one part of the treatment continuum, or right, or you could potentially consider exploring the whole thing, the entire treatment continuum across the levels of care. We want to hear from everybody. For this experience, one of the things that was important about the Lee County survey is that um, it was the entire continuum that was surveyed, because there was no other way to answer the question around wait times that people had. And the reason is that when the survey was done, what came out was that there was a particular provider who had a 3-month wait. And the general consensus in the community was that that level of care was not available because that provider had a 3-month wait. Had we only surveyed that part of the continuum, we would have concluded that that wait dynamic was real for the entire system. And what we actually found was that that same level of care was available within a week at 3 other providers in the region, for whom many of the providers didn't even know they were providing that level of care. So I name that because I think one of the things that you all think about is, just to sort of take it back to some of what Katie said, what are the questions that only providers can answer? And are there questions that are important to only a certain part of the treatment continuum? Or are there questions that the only way we can get a true answer is to survey the universe of the entire continuum? So I think as you think about your priorities, and we have this discussion, there might be very specific things that you would say as a treatment committee to implement the comprehensive plan. It's important that we understand certain things about ASAM level 3, as an example. Well, so what does that mean in terms of building out a survey if we want to know specific things about each part of the continuum? So I think as you think about, and I'll throw in the chat some of the summary questions that Katie said because they're right on point. What can be best answered by providers? What are we going to do with those answers? You want to be careful not to ask about something that you don't intend to do something about or activate around. So it might be, are you as a committee wanting to get a broad baseline of the state of the system so that you can then evaluate progress in comprehensive plan priorities in 3 years and 5 years, et cetera? Or is there a particular priority in the comprehensive plan that you feel like you need to hear from providers about, but there might be some other priorities that it's an important question, but we don't want to ask right now? So I would just put that last piece in mind as well. I'll maybe take a pause there because my goal was to be sort of just a listening body and a resource and offer opinions as is helpful to you all in your discussion. I'll throw again some of the sort of key areas that Katie already outlined in terms of what to think about. But I would just echo Mitch's point and that he said as well, that I think at the outset of the plan is a good moment for you as a committee to think about what do we need to know from the provider community to move our near term goals forward in implementing the comprehensive plan. So I'll take a pause. Turn it back to you, Katie and Bradley.
Thanks, Tim. All right, as we move into this discussion, I think curiosity is probably the most important thing we can bring into this conversation today. So go ahead and start off with one. Let's see how everybody's feeling with this question, and then we can. Or does anybody have any questions for Tim or comments or feedback? I should have started with that. I'm sorry. Okay. So yeah, so now to you guys, to the committee, what questions can best be or only be answered by providers? Should I call on people? Go ahead, Joe.
I really feel like providers are best able to speak to their referral pathways up and down the continuum of care and where their pain points are. So, one of our plan priorities is to facilitate improved transitions throughout the treatment and recovery journey, and
Hey,
also to.
Joe, would you mind leaning in just a little bit more on your mic? Sorry.
Oh, sure, yeah, actually, and I can turn this up a little bit. How's that? Great. So these two plan priorities of facilitating improved transitions and ensuring timely access at all entry points. I feel like providers can really help us understand how we can support those by speaking to their case management and referral pain points. That was, especially in and out of withdrawal management. Also taking into account housing. It's a it's a constant it's a constant pay point when it comes to referral management. So I think that's something that would be wise to include in any sort of questionnaire that goes out. How to phrase it, how to keep it succinct. As Tim mentioned, the more questions on these things, the fewer answers we're going to receive. So, yeah, I'll leave that to brighter minds. But definitely when it comes to case management, I feel like we want to hear from providers directly all throughout the continuum and housing.
Thanks, Joe. Who else has or what question or might be able to provide answers to the question about questions that can best be or only be answered by providers?
I guess for me, what came up was like, what staffing challenges most affect like service quality? I mean, I know we all have staffing challenges, but like, which are those positions that affect the quality? Um, or like, what support would help stay or help staff stay in the field longer, or training gaps, or maybe how staff are coming? Are they, they've gotten their CADC or their peer support? Like, I don't know, some kind of question around the training of the workforce available, what's working, what's not, maybe. Uh, and then the other questions I have would be more about, and I know we've talked about this, but treatment effectiveness. Like, what practices maybe should be expanded and what practices maybe should be reduced, or that they're seeing better outcomes than others, or are we missing services entirely?
Or you made me think of a question, or like on top of what you were saying, or piggybacking on top of it. I was talking to a different field about how they train individuals, and then those individuals take that training and go somewhere else where they're getting paid more. And so I feel like that's significant in behavioral health as well, especially, with CADCs. I just wanted to throw that out there. I don't know if that's a question. Well, that is a question I guess only providers can ask. Like, what's that retention look like after being trained?
Yeah, and I'd say my experience, and because I've been looking at other states too, kind of what they do. And there's some states that you have to work in the field for a certain amount of time in addition to the training that's provided, or there's the training, and whether it's paid or unpaid, that you have a certain amount of hours that far exceed what our state asks for.
I'd like to know about coordination of care between agencies and different providers. Very few, I come from the world of CMHPs, and very few CMHPs, thinking back to Joe around housing, offer housing services. We also have a system set up that it's really competitive. So how are we building a system of care and coordination of care when we're also teed up to be competing against each other?
I can speak also to that a little bit. And hi, Lisa. Good to see you again. Um, I feel like the like how the decision about where to refer to is made, and the like how people how service providers are determining what sort of programmatic options are available out there in the community. I think in metropolitan areas, the options are very varied and multiple, but in rural areas there are fewer resources. In my experience, a lot of it is just by word of mouth. Like we know someone over there at that organization, so let's call them up and see if we can get them in today. And it just seems like we can do better. So curious about how people are navigating who they refer to.
That also, thank you, Beth, for saying that. Also, really good to see you. It's been a hot minute. That makes me think of treatment bed availability and kind of the barriers as it relates to the different regions where there is availability. Katie and I were in a meeting with a provider on the West Coast, and we were talking about this, and he was saying, "Hey, we got beds available." Meanwhile, on the east side of the state, it's like you are fighting people to try to get beds for folks. So, really, kind of maybe taking a deep dive in terms of what kind of barriers exist for our different providers based on the region that they're in.
I have a few, but I don't want to jump in if somebody else is going off mute. Okay. So in the spirit of rural frontier, I think a good question would be what evidence-based practices are difficult to sustain in the rural frontier settings. Also, what administrative or billing burdens limit implementation capacity? And not just for rural frontier, but kind of like Beth, what you were saying, kind of a little bit of that too, is what partnerships are working well locally and where are collaboration gaps occurring? Um, am I going too quick? Okay. I know, Metro, don't want to make sure you're furiously writing all this down. And then I guess another question I have, oh, that's impressive, 130 words per minute. And how do wait lists, transportation barriers, or housing instability affect treatment engagement and retention in those rural and frontier communities?
I think also regarding bed availability, another factor that would be worth talking to providers about are what demographics or presentations are clients presenting with that are limiting what beds are available to them. Because I know that individuals with various legal charges on their records have even more limited options of where they can go compared to, their counterpart that doesn't have that legal history. And then that even more severely limits availability of resources. And so then the question becomes like, how are providers navigating that? What are the legal charges or other kinds of barriers that they're seeing the most as being the most challenging to navigate? And then how are we addressing like programs that are able to take those individuals? Are those providers actually taking them, or are they always filled with clients that don't present with those additional needs? So I think that that's kind of a pile of stuff.
I'd also like to add on to that co-occurring disorders. That seems like a significant barrier. I'd like to hear more about. Gosh, there was another thing, and it's gone from my mind.
I have a question that I don't know if anybody else in the state has experienced this or if it's just in Lane County. We've had Oregon Health Plan switch from to just Trillium, and they have stopped. Yeah, I see the faces, and they have stopped reimbursing for residential treatment past 30 days. So everybody who does get a bed is getting sent home at 30 days and it's not working. And so I guess the question, if I posed it as a question, is what Medicare, Medicaid reimbursement policies are affecting your ability to provide effective treatment to those who do make it into your program?
I also wonder about, and this could be opening a can of worms, but what OARs
Yeah.
impact those same, right? Like what
Yeah.
promote those treatment and what actually causes more administrative barriers to those treatments? Because like I have ideas, but I think depending on what level of a provider you are, there could be specific things that might be easy to fix from a legislative perspective that they would know best.
I just remembered this is kind of going back to residential treatment. I'm also curious about transition care. It seems like we have a lot of providers who we send folks out, but what are we doing when we receive them back to our community?
Really quick, when you say transition care, Lisa, can you speak a little bit more about like what sort of transitions?
I think one of the biggest gaps, working for a CMHP, one of the biggest gaps I see is we'll send folks out to residential treatment, or other providers will, and then we kind of lose track or sight of them. We don't know when they're coming back. When they do come back, are they getting the proper support that they need? If it's a little more complex of a client or a co-occurring client, are we ensuring that there's proper step down if they went to a facility where step down care is a thing? What does that really look like when we receive them back?
And to piggyback on that, Lisa, because Eastern Oregon is so spread out and there's only one withdrawal management in our area in the 12 counties, right? If someone leaves AMA in Baker County, but their or county of origin is in Pendleton or Boardman, right? Like, where are they at? And are we, is there collaboration and what does that transition look like? Because individuals can be lost or have been lost in that transition. So,
Yeah, and being in Eastern Oregon, it's not uncommon for us to send folks to the west side, the Portland area, and that's even harder to track.
Similarly, in terms of transition, something that we run into a lot in Southern Oregon is that if we have an individual presenting with complex needs in a residential treatment program, when they're ready to step down to a lower level of care, there becomes the game of where do they go if they need more than, if they are presenting with barriers associated with a physical disability or developmental delays or a complex medical issue. And, they came to our res program directly from the street, or directly from jail. So now what? Or our facility is one of the few in the state that will occasionally, sometimes take registered sex offenders. And then if those individuals need a place to go after res, I mean, who takes them? Like nobody. So then it becomes a game of like, now what? Because, you don't want to literally dump someone in a campground. But we've had clients choose that because there isn't much.
I just want to say, Katrine, like, great call out on the sex offender piece of it because I think it's not talked about enough, but it needs to be, right. So just wanted to call that out.
I would like that to be specifically like that, a specific question about sex offenders because that is a population that nobody will touch and they need services too. They're human beings.
I totally agree. And we specifically have that problem with treatment courts. So um, I'm very interested in the answer to some questions about that.
And yes, Mitch, I agree with arson as well. Like those are kind of the two, the two gnarly ones, right? That a lot of like transitional programs, group homes, even residential facilities will automatically rule out. So then again, like if my res program takes a client with either charge, we risk then not knowing where to take them next. And in fact, kind of new crappy solution we've run into so that we don't get stuck holding someone for too long is that if we have somebody referred to our res facility with a sex offense charge, we're now requiring that, and I mean, you can only enforce it so well, but we're requiring that the referring party be able to provide us with at least a tentative step down plan before we even take them in, because otherwise they come in and we have nothing to do from there.
I'd also be curious about transition care for AICs, so adults in custody, and how we're supporting that population as well. Because if they are receiving services while incarcerated and they come out, then now what? And are they a unhoused sex offender? Now what?
I was going to say too, unfortunately, because of funding issues too, I know Multnomah County just got rid of their entire transition services program, which was one of the best in the area, which confounds that issue. If you don't have places for AICs to go, I think right now it's a really, it was bad as it was, and there was some light, and I fear with the changes in the local county levels, and then who knows what the elections will bring in November, it doesn't look really exciting. So whatever we can do, hopefully to come up with some strategies in these spaces will be so good because it's so needed.
I don't know how to put this into a question, so I'm going to talk it out a little bit. But when you have ASAM requirements, right, that ethically, when I've done ethics, they talk about ASAM requirements, and then you have your OARs, and then you have Medicaid and insurance and CCOs, and they do not align. And yet, which ones are taking priority, and is that helping the person? So I guess maybe like, are current regulations supporting effective treatment delivery, or like maybe funding structures, do they align with actual client needs? I don't know. I'm also open to more questions if that, but yeah, I also live in Lane County, and sometimes those rules just don't. There's more to it too. Like IDT, you only get 2 weeks in outpatient. There's creating timelines. So I'm just like, what policy changes would most improve those outcomes, and then what accountability to the CCOs have to even comply?
Love Martin Lockett, by the way. Just want to throw that out there. It's being recorded, so.
I just can't, stress enough what Mitch brought up earlier, the impact, and this is with regard to payers, and treatment providers as well, and the intersection there. But co-occurring, this idea of high acuity is often used as a means for shuffling individuals throughout the system, and it's with reimbursement being what it is, it becomes a business case for if an individual is providing any challenges to our system. There's so much service that can be provided before there's a business case to say that they would be served better elsewhere, or that we are unable to provide the services. And oftentimes, the connection between SUD services and mental health providers and the payer impacts of that connection, folks aren't receiving the co-occurring care that they will need to have a successful journey through the continuum. How does that look? I'd say in a question, how does your organization currently provide in-house mental health services? And if not, do you have streamlined and available pathways to mental health services, including medication management? Because just counseling alone, a lot of times, is not going to be sufficient for individuals, especially folks that are coming straight off of the street or otherwise coming out of active addiction. Even the phrase co-occurring is kind of silly because it's really 100%. Like, it's a behavioral health condition. So I don't know exactly how to phrase the question, but I'd want to know: do all treatment providers currently have medication management and also at least QMHP level providers? If not, actually social workers or psychologists on staff? And if not, do they have streamlined pathways?
I wanted to call out the eating disorder comment because I feel that's also not talked about enough, or we're just not seeing the importance of it. And along the lines of the sex offenders and AIC and what Mike put in the chat, such a great call out.
Just to go kind of piggyback off of Joe a little, even if they do offer, like if an agency does have mental health providers, QMHPs, whatever, what is the wait time to get there? So, I mean, that even if they do offer that, like, is that quality? Are we prioritizing maybe some of these highly complex SUD clients, recognizing that the care they require out of the hands of clinicians, CADCs? What is it, 3 months? Is it 6 months? Is it a year? I mean, you can have that, but is it accessible?
And along those lines, the prioritization criteria for res treatment that facilities are being required to implement by OHA, like prioritizing, IV drug users, is resulting in individuals who may technically be in a situation of higher risk and higher need that sit on the wait list potentially forever because there are so many individuals that meet prioritized criteria that will always take precedent.
Sorry, I was just reading the chat. The benzo use disorder dependence, that I absolutely agree with that. And what are we doing with those individuals, right? That require that. Some great stuff in the chat, Mitch. I don't know if you're capturing that or will later, so okay.
The other thing that we haven't talked about a ton, that I think providers probably are best to comment on, is funding of all of these things. Like, how is it fee for service? Is it value-based agreements? Is it grant funding? Is it all of the above and it's still not working? Just trying to get a better idea of how some of the programs stay afloat, I think would be important. And that's information that's harder for us to discern from like claims data, and other sort of resources.
That's such a great point. And, the value based models, I feel like there's so much potential there, and they're very difficult to negotiate, especially when it comes to like the MAT and outpatient setting. There's a lot of potential there, and that's maybe something that ADPC could actually affect some, I don't know, but potentially affect some change, helping payers, at least Medicaid payers, understand that value based models could end up saving them money, providing better care.
I wanted to also, there's another question too. Can the questions that we're providing or asking, can they be answered by a single type of provider or would require multiple types? And then also the third question, what type of intel are we looking for, such as financial, pragmatic, administrative, factual opinion? Want to throw that out there too.
Um, on technology, like I believe, so I used to work in the IDD field, and I believe the state is working on one system that they could operate off of. Uh, is there like an electronic health record system that they believe would support effective care or a universal system, possibly data sharing between organizations? Or is that sufficient? Has telehealth has that improved access to services? Is staff adequately trained on technology systems? And then just thinking when I started, like the documentation, I remember the paper days, the paper files. Um, so I'm sure it's a lot easier now with EHR systems, but I'm curious on what level of the documentation requirements impede on maybe other things like collaboration of care, and or if a CCO is asking for an updated treatment plan or an assessment, is that extra workload creating the barrier from maybe another way to just extend someone based off of without having to do the full meal deal? So I don't know, something around the documentation, and is it creating any barriers? And if so, like which kind? Oh, and then the last thing I had was around detox. And that I know that one's really specific, but detox. So I operated detox facility for years. Um, but with fentanyl is a whole different drug, and I don't think there's any two different agencies that are running alike with their medical protocols. And the same thing even with MAP providers in some cases, where some people are transitioning people just onto the MAP service of the Suboxone. So say a fentanyl detox could only be 3 or 4 days, while someone else, maybe that's 10 or 14. What are the best practices for the drug that we're seeing today and that we're seeing that's working? And what are we counting as working?
So I start saying something and then the chat like catches my attention and I get get distracted. And as another reminder, if there's public comment, I know Ashley had alerted me that we do have somebody with public comment. So if anybody else does, please message Ashley directly, and we can make sure we get to that. Um, and if there's anybody here that I think Mitch, you had said earlier, from the public that has anything they'd like to throw in there, please do so.
Just as a listener and appreciating where you guys are taking this conversation, I'm taking notes like Mitch probably. And what I'm doing is like, okay, is there a way to categorize what you're asking for? Going back to like our example in Lee County, where we sort of had we created a large survey, but we sectioned it. One other thing I would, in addition to the other questions and frames that Katie's giving you to think about, um, and I think this was true in both of those instances and in some other instances where we've done some complex surveys in the provider community, is to also sort of check in around what is it that providers are hungry to tell people. And because I also think like part of in some of our experiences, even when there has been concern about will we get enough provider response, what we have found in retrospect is that there were questions that providers have been wanting to be asked for a long, long time and have never had the opportunity in a formal way to elevate their voice on that subject. I see, I mean, as I'm even just watching you all respond to each other's ideas, I see the excitement in some of you to be able to put some of that out there. But as you think about your colleagues and other providers in the field, I would just throw that in too, as you sort of as you think through other topical areas. Is there something that you think that that maybe has not been discussed yet or raised yet, where you feel like, wow, providers, if they were asked that question, they'd be really eager to have an opportunity to answer it?
Can I don't want to put you on the spot, Judge Rigmanen, but one of the things that we've talked about like from carceral settings, but not so much the like community court setting. I'm curious where
Mhm.
this all overlaps and if where those questions might need to be.
I'm not sure I understand your question. I mean, we use a treatment provider that we contract with. We use Emergence, and um, they work with us and they follow their best practices. And we work with a lot of different inpatient providers. So, um, I mean, we're just using the same community resources that everybody else is. We're just referring people there, and we have the same issues that have been brought up. We have issues with sex offenders. We have issues with people with arson on their record. Um, we even have people with a sex offense on their record who aren't registered sex offenders. Um, so um, we also have issues with people with co-occurring disorders not having placement. We've had people, yeah, and so we're mostly dealing right now with the Oregon Health Plan issue and funding being pulled from those insurance payments. Um, we've had one issue that's come up that I don't know if anyone else has encountered, where someone will be on the wait list for residential treatment, and they're making calls weekly to try to get in, and they have to keep their name on the list, so they have to keep calling. But in the meantime, they're continuing active use and they're continuing to participate in outpatient treatment, because for my program, they're required to continue doing outpatient treatment. And Trillium will say, well, we're not going to pay for outpatient treatment anymore because it's not the level of care that they're assessed as needing. So they can't do outpatient treatment because it hasn't worked. They've been doing it for too long, because the wait list is so long that they have to wait that long. So the insurance company is creating this sort of catch 22. And so that's one issue that we've encountered a lot, because for my program, they're required to do outpatient treatment until they get into inpatient, but insurance wants to cut them off.
And that's insanity, because
Yeah.
it's actually
Yeah,
in the
thanks.
insurance best interest.
That's really affirming for me.
I mean, insurance should be excited when a client is willing to engage in treatment at a lower level of care that costs less,
Yeah.
because, we have clients that will like be in day treatment waiting for
Mhm.
res, and
Exactly.
eventually they demonstrate progress and no longer need residential. Like, that's
Right.
beautiful when that happens, right? And
Right.
now that bed is opened up for somebody else. So that
Right.
blows my mind.
Yeah. So that's one issue that we've been having. So did that answer your question? I don't
I
know if I
always and this is like a weird I've talked to a lot of committee members about this. Like there's always like very specific questions that I have that I keep in mind for each committee member. And very early on, you were like, community courts get forgotten about. And so I've just been like, that is not what's gonna happen here. So that you answered my question in tenfold more.
okay.
I think that really reinforces what Tim was asking, like what are providers wanting to talk about if asked the right
Yeah.
question.
I bet they'd want to talk about that. Yeah.
I know I've talked a lot in this meeting, but I still have something that came up and it hasn't been talked about. Um, Cultural services. We talk about person-centered services. I'm curious how treatment providers, because it's within the OARs and the COA when you're applying, how do you scale that, right? That you are even providing that um, in a way that is helping people that tend to see less of each other in the environments that they're finding themselves in. And also thinking about, individuals with criminal backgrounds and mental health, also just overall with populations. When I went to treatment in 2003, my counselor got excited because of how bad I was. And now I've supported clients to treatment. And as soon as they had an attitude, they told them to get out. Like it was, and I'm seeing more and more of that. So like, I don't even know how I'm saying this, if I'm saying the, yeah, how do treatment providers look at, are they providing services to underserved populations, and how do they rate it, and how do they deal with challenging behaviors, um and if they could change something that they think that could enhance that, what would it be? Yeah.
Just to kind of tag on to what Art said, and I also know I have been talking a lot too, so I apologize, but I really think about quality of care, right? Like how knowing what the workforce shortage currently is and what it's expected to be by 2030, and how I feel like very loose and fast we play with treatment providers for drug addiction in comparison to the expectation of education, of internship on the mental health side of that. Like, how quality are these providers, and what assurances are in place to make sure that we're not creating more harm than help? And then I just always keep kind of coming back to the funding piece. Funding gets cut here, it gets cut there, but the expectation to provide quality service continues to climb. We talk about matrices and we got to tie these back to measurements. Where's the funding for that? And where's the funding for the training and the professional development and the workforce development? And what does that landscape really look like? And especially in some of our poorest counties in the state, which happen to be on the east side of the state.
Lisa, that's a great point. And an example to some of that is OHA has ICOD certifications now. And I know I put this in the chat, but I've had agencies do presentations that they're ICOD certified, but they're not actually changing the population of what they were providing before. But now they're getting an enhanced reimbursement rate. So they're getting paid more, but there's no quality check. Are they helping people more to open up the populations that they weren't previously doing? So if there could be enhancement rates, but with accountability that there's change, would be great.
And I think that also ties into maybe the broader issue of pay equity when you're looking at in the behavioral health field, right? Like, how do we expect to retain quality people when there's a very significant cap there in terms of pay?
So, Mitch, I was reading your request for a public comment. I was throwing in some questions to ask that might like create or might give providers opportunity to really like say their piece in that spirit, or they feel like they might not be asked, and might get some valuable information. Um, so all right. Does anybody have anything else they want to add? No, this has been a great conversation. Great. It's been very productive. Is it like appropriate to ask providers specifically, and this might, I don't know if this is appropriate, maybe it is, but to say their piece or how they feel how burn has worked for their services, and if it's, just maybe give them an opportunity to talk about that and maybe they haven't been asked if they didn't receive those dollars and what has been successful, or maybe there's barriers within that. Again, I don't know if that's too much of a hot topic, but it'd be interesting to find out how they feel like that went or is going in their communities.
How it could be better. Yeah, that's a great point. Yeah.
Awesome. Um, I know, Ashley, you had said that the individual that wanted to make public comment had to leave but they did leave a statement. If you want to go ahead and do that real quick. And then Mitch, afterwards, if you want to do your public comment.
Great. Hi, everybody. Rachel Mark, a treatment court analyst for the Oregon Justice Department, reached out with a public comment during this meeting. She started off saying that she really appreciated this conversation, and here is the public comment. I know there are several challenges to access for all populations, but the challenges with the justice involved population are significant. Many have been raised, but the issue of ability to serve high risk individuals limits access for some of the individuals who need the services the most. Additionally, I wonder if a question we could ask ourselves across systems is how to leverage our partnerships and roles to serve individuals at the levels they need to avoid preventing future harm. As an example, sometimes because treatment is voluntary, providers tell people that they don't have to do treatment or it isn't recommended due to lack of motivation. But the court is mandating they follow through with the recommended levels of care. If the person is not recommended for the levels they need, they often continue with problematic behavior that leads to more severe legal penalties. And that is Rachel Mark's comment. I did not receive many others.
Thank you, Ashley. Go ahead, Mitch.
Yeah, no problem. Mine is the joke was public comment. I forgot I was supposed to update you all on something I said to hold me accountable for. So how dare you all not hold me accountable for this? I sent out the work group invites for our two work groups that are kind of spawning underneath this committee. There's a best practices work group and a work group for medications for substance use disorders. If you are interested in either of those and you did not get the invite, these are not closed to the committee. These are open to the public and agency partners. Please just email me. I'll put my email in the chat right now, and you are more than welcome to join those. The first one of the best practices meets this month. The medication group will meet next month though, because there's a holiday on the day that it would fall. So I did follow through though. I did follow through with what I said I would do.
Awesome. So everybody sign up. Or you'll be voluntold. I'm kidding. We don't do that here. Maybe we do. I don't know for sure. Maybe not on record. Um, I uh I know Bradley's here, but he isn't feeling super hot. And I just kind of wanted to point something out on his behalf, if that's okay, is just really bringing up. I know a lot of these questions or the conversation has been focused on behavioral health systems. And so really I know we only have about 11 minutes, but really thinking how the physical space or physical health space can also be a part of these questions because there are physical health providers that do a lot of this as well. I mean, maybe not, the full continuum, but with the MOUD prescribing and other uh, levels of care, like that, I think it would be important to make sure that we're um, including those providers too. Um, and I don't know if anybody has anything to add to that or any um, questions they may want to add to that or add to the growing list of questions or short conversation about that real quick before we wrap up.
Can I ask a question about what the process is for dissemination of a survey like this and how we select service providers?
Yeah, floor is yours, Beth.
Oh, that's my question.
Should have, sorry. Great question, Tim or Mitch or
Yeah, I mean, I'll just speak from experience in other arenas where groups have arrived at sort of a similar suite. And actually, it's happening in real time with the prevention committee right now. I think when you launch something, if you were to, as a committee, opt to launch something as robust and as comprehensive as you're talking about, I think the ultimate goal would be to find every communication vehicle possible to get this opportunity to participate in a survey in front of every provider in the state of Oregon. Right. So the prevention committee, as an example, there is specific outreach being conducted to various trade associations and sort of sub cohort groups like school districts and particular people who might run, drug-free community coalitions, et cetera. So, and I think it would be, I'll say to you all, what we shared with the prevention committee is they're preparing to launch we're preparing to launch that provider survey, which is the success of that survey is going to be contingent on the leadership and voice of many of the leaders in this room or on this Zoom, for lack of that, because I think ultimately speaking, it requires some network weaving and promotion across as many channels as are possible. And that's where, like, not only ADPC, but can OHA send information out to contractors? Can you all distribute it in your networks? Can the CCOs get it out? Right? I think you have to. There's a communication strategy that comes along with the survey. If you want to cast as broad a net as possible, and I think we found in those instances that is the if there are influencers, for lack of a better word, who can promote and reinforce a survey like this, you're bound to get more engagement. I think to the extent primary care or physical health got referenced, if you as a group contemplate, are there sort of a further orbit of stakeholders that you might want to weigh in that normally don't get engaged in this kind of dialogue? It also is an opportunity to think from an outreach strategy standpoint of, does this create a moment for us to build a relationship with a part of the healthcare sector that the collective we is not yet engaged, and perhaps the survey becomes a tool to do that outreach and engagement and a reason to ask those players to show up at a table where maybe they haven't before. So I don't want to undersell or undercount the fact that it does take work to get to, particularly the broader you want the survey.
I just with Tim, I also just wanted to add on, especially in those rural communities, right, where detox or medical detoxes aren't readily available. I think one of the solutions is to really rely on physical health, right, to help with outpatient detox. And so I really think considering those physical health providers is super important when it comes to these questions or a survey. So.
And then I think the last piece, apologies, just which ties into that, is what you do with it once you get it. Because I think, in Lee, as an example, the result was a slide deck that was shared publicly at public meetings in the community. In the case of New Hampshire, it was a written report with slide decks and sort of a road show, for lack that I know the ADPC has used that term before, but it was marketed, it was used. Like the results were taken out in very strategic ways afterwards, not just to inform and drive the decisions of the decision makers like you all, but as an outreach and community engagement piece afterwards, because then you can reflect that information back in the community.
I have a
Go ahead, Art.
question on that, Katie. So I wasn't part of developing the plan. I've only been on here for, I don't know, maybe 5, 6 months, but was there ever a survey that was done to show is there lack of services of map providers being available? Um, and are they in certain areas that is looking at creating this? Because detoxing at home with a mat service, like primary care providers themselves already like have been prescribing opiates for so long, right? And they've done a lot of other things. Getting them involved, is the education going to come along with it or the requirements there? Is that the focus? And is that a higher level than maybe looking at why is there only a 16 bed under COA for an actual detox? If we need more detox space, which one would benefit the most? Maybe having more beds in detox available, which then would bring more companies because then they could actually make their money back. Or is it having people that maybe aren't have that training or education to start prescribing something? I'm just curious where this came from.
Yeah, I can actually speak to that. So there are kind of two things that being done. So one thing you'll see in the plan and the near term objectives is mapping out where withdrawal management providers are throughout the state. What we've been doing simultaneously to that is trying to figure out how we can map out the other provider types. This is also a big reason that we started the plan for the annual APAC analysis is to actually see what prescribing rates are occurring through MOUD. And then there's some other work that we're trying to do internally with agency partners to develop a better understanding of like where that's happening. The challenge with APAC is that it is dated, so we're always like looking back in time. So it is something we can definitely try to do better. But yes, it is something that we have like a measurement of at least up to 2023 on, and we're trying to improve the recency of that data.
Thank
But
you.
nationally, we fit the trend of when the X waiver went away, the same amount of prescribers stayed in the system, but the amount of patients went up. And so that's still sort of the problem there.
Thank you, Mitch. Any other last minute questions or comments before we wrap things up? All right. Well, thank you everybody for the discussion today. Like I said, it was great to have everybody involved and throwing things out there. And I appreciate the level of thoughtfulness, honesty, and curiosity that people brought into this conversation. It was great. Okay, so thank you to Mitch and Tim. It was great to see you again in our committee. And the everything that you've put into helping and supporting. It's been wonderful having you here in our committee meeting today. If there's no additional business for the committee, then we'll go ahead and adjourn for today. And thank you everybody for your time and participation.
Thank you all. Bye.